Great to have you all here. My name is Tom Blonsky, President and CEO of Catholic Charities New Hampshire. I'd like to start by thanking New Futures and New Hampshire Medicaid Matters for putting this series of community conversations together throughout the state, and by acknowledging the work of the 100+ member Medicaid Search and Rescue Coalition, represented mostly by New Hampshire nonprofits, which has been working over the last couple of years on multiple Medicaid-related issues. This coalition is also actively navigating how various Medicaid cuts that were voted on via the big, beautiful bill last July will play out at various points in time over the next couple of years in New Hampshire and around our country. Whether it's work requirements, increased premiums, or reduced eligibility for Medicaid, or reduced eligibility for SNAP, that best support our Medicaid eligible or formerly eligible populations, our most vulnerable citizens. Many of you have probably heard the saying that the measure of a great society is reflected in how we treat the least among us. And this $1 trillion cut in Medicaid services over the next 10 years is at the heart of this. We at Catholic Charities, in one of our best known programs, the New Hampshire Food Bank, are doing our parts to respond to the ever increasing needs of this population through additional food distribution, counseling, increased case management services, by building affordable housing, by caring for a higher percentage of Medicaid residents in our nursing homes and boldly advocating on behalf of them, and more. And through the years ahead, we look forward to continuing our partnerships with many organizations to augment our supports and uplift the lives of those who need us the most. Now I'd like to introduce our moderator, Christine Stoddard of Bi-States Primary Care Association and a member of the coalition.
Good evening, and thank you, Tom and Catholic Charities and the New Hampshire Food Bank for hosting us tonight. Michaela, is this sound okay? So the reason why we need mics, everyone, is because we have translators in the front, and also we're recording this and it's live streaming. So if you have a question or a comment, please use a microphone when we get to that point so that everyone on the internet and their mothers can hear you. So my name is Christine Stoddard. I am the Senior Director of New Hampshire Public Policy at Bi-State Primary Care Association. We advocate for increased access to healthcare services in Vermont and New Hampshire, and we also have the privilege of representing community health centers in both states. Our health centers work to increase access as well because they treat patients regardless of their ability to pay or their insurance status. They do not turn people away. So first, we're going to do a first few housekeeping items. It's my understanding that the bathrooms are that direction, to my right, your left. And we will have time for questions and comments at the end of the discussion following the presentation materials. There are packets available at the entry table where you signed in if you would like one. But you can also get more information on our website, and the QR code is included in your materials. So tonight we're going to be joined by our friends Deb Fournier from UNH and also Chris McCracken, the CEO of Medicaid. Oh, I need to advance this. So we talked about that. So tonight, thank you, Michaela. Yep. We'll be joined by Deb Fournier, who's the Director of Health Policy at UNH's Institute for Health Policy and Practice, also the former Medicaid Director for New Hampshire, and Chris McCracken, who is the CEO of Medicaid Health, which is a community health center in the Manchester area, but they serve the broader Manchester campus as well. So as Tom noted, Medicaid Matters is a group of more than 80 organizations, I think, that work together to address Medicaid policy changes, not only at the state level, but the federal level. And we do this because we want to make sure that people who need access to care can access that care in a timely and efficient manner. The other reason why we do this is because guess what? If your neighbor loses their health insurance, that will affect you. If your friends down the road lose their health insurance, that will affect you. And it's because the more people who lose insurance, the greater wait times that you'll have at the emergency room, because people will delay care because they can't afford to go to their primary care practice. And it will also mean more wait times at the primary care practices. Because if you people have insurance, it's better for everyone. So please be concerned, even if you don't have Medicaid, even if no one in your family is covered by Medicaid, please be concerned because the upcoming changes to the Medicaid program at the national level and at the state level will affect you. So Medicaid in New Hampshire goes by 30 different names. It's a lot. It's a mouthful. But if your insurance card happens to say New Hampshire Healthy Families, AmeriHealth Caritas, or WellSense, you could be covered by Medicaid. So WellSense happens to have a plan that they sell on the marketplace. So you might want to check into that. If you're on what's called the Granted Advantage program, which is New Hampshire's version of Medicaid expansion, your insurance card will say one of those company names and then also Granted Advantage. So as I noted, Medicaid is an important program for everyone, not just the beneficiaries and the practices that accept Medicaid as reimbursement. New Hampshire, the state of New Hampshire, accesses more than $500 million a year just in federal payments to the state Medicaid program. That's a lot of money, especially for a state that doesn't have tax revenue, right? We have very little revenue outside of business taxes and federal funding. So the fact that we receive over $500 million a year is very important. So it supports the healthcare workforce, right? But it also supports every workforce in New Hampshire. Because if you have insurance, if you have Medicaid and you need to go to the doctor or you'll miss work, you can go to the doctor. You can access health insurance. It also means that if healthcare organizations that are taking care of you that accept Medicaid won't lose money by caring for you. So they will get an insurance reimbursement from the Medicaid provider, Medicaid insurance company, MCO, for your care. Medicaid also is one of the biggest payers, insurance payers, for community-based private provider organizations like the community mental health centers. It's also a big payer for the community health centers and also the rural hospitals in New Hampshire. So many of our rural hospitals exist and can stay open because of our Medicaid patients and those payments that they receive for treatment. Having Medicaid insurance cover over 180,000 people in the state of New Hampshire means that those healthcare organizations that treat those patients receive a reimbursement for that care. Yes, it might not cover the entire cost of care. It's true, but it covers a good chunk of it, and something is better than nothing, especially in this economy. So it reduces the uncompensated care or unpaid care for the healthcare organizations in the state of New Hampshire. It also generates a lot of revenue because, like I said, we're getting over $500 million a year for Medicaid, but then that money is also used to pay for your clinicians that you all see and that your family members see. It pays for the staff at schools in the Medicaid to Schools program. It helps support those staff. So it's a big funder of our state revenue and workforce. So in the city of Manchester itself, so this slide does not include the outlying towns that are also served by Medicaid. Just in the Queen City, there's over 18,000 of your residents who are on Medicaid, who are insured by Medicaid. There's almost 8,000 residents just in Manchester alone who are on granted advantage, which is New Hampshire's form of Medicaid expansion. So that's a good number of your friends and neighbors. So now we're going to talk about a little bit about what Medicaid is. I can't tell if I'm clicking it. You are. Oh, is it Deb's turn? It is Deb's turn. So now I'm going to turn it over to Deb Warner from UNH. Thank you.
Hi, good evening. I'm Deb Warner, the Director of Health Wellness Policy at UNH's Institute for Health Policy and Practice. Thanks for having us and thanks for coming. I am in fact guilty of being a former Medicaid director for the great Granite State. Great job. No complaints, no notes. And I love talking about Medicaid. So that's what I'm here to do, is to just provide a really high-level bird's eye view of Medicaid. So Medicaid is publicly funded health insurance for low-income people. It is jointly administered between the federal government and the state government. The state doesn't have to have a Medicaid program, but currently every state in the union has elected to have it, including New Hampshire. To have a Medicaid, if you choose to have a Medicaid program, there's some certain basic rules that the state has to follow. It has to cover minimum groups of people that are called mandatory populations. That's right. And they have to cover minimum services called mandatory services, also something. And then they can choose to cover what's known as optional services for optional populations. And in return for doing that, the federal government, and I promise I have a point with this, the federal government always pays a fixed percentage of the cost. And it's always at least 50. Okay, sometimes it's much, much more. And tonight we're going to talk about people for whom it is much, much more. Okay, that fixed percentage, it's called an FNAP, 50%, ensures that no matter what happens in the country, that there's financing at the federal level sufficient to meet the need. So if there's an AIDS crisis, or there's a Great Recession, or there's a COVID pandemic, the federal financing expands as the enrollment expands. Right? Because those things throw people out of work, and then they need health insurance. Because in the United States, we predominantly provide health insurance through employment. Okay? So Medicaid is a publicly funded health insurance program. The feds always pay 50% of the cost, sometimes way more. They historically provide it to this four group of people. The statute was written in 1965. And I just said like 2 seconds ago that we provide in the United States, we do health insurance through work, right, through employment. In 1965, what did those people have to do with work? What do they all have in common about employment? They don't work, and they weren't expected to work, right? And so the government created a program to be like, okay, we're going to fill in that gap, right? Okay, then fast forward to 2010, there's the Affordable Care Act, and I'm sorry, I got to go back. Who's not on that list? So there's babies and kids, there's pregnant women, there's older folks, and there's people with disabilities.
Working adults.
Right? Chris doesn't get to answer any more questions.
Military families.
Military families actually get their own coverage, but
And veterans.
right. So for this program, the people that aren't covered are low-income adults. Just people who are just low income. They're not living with a disability. They're not expecting a baby or haven't recently had a baby. They're not a child or a baby themselves. And they're not an older adult, right? So fast forward to 2010 and we have the Affordable Care Act. And the Affordable Care Act creates a eligibility group called the Medicaid expansion. They're in the yellow bar. This chart shows you all of the different income ranges for the different eligibility groups for people in Medicaid. So, and you can tell that the statute, like we added eligibility groups on over time. Our income eligibility at the top, the purple, is for people who are living with a disability and are employed. So we want to allow them as much flexibility as possible to get Medicaid coverage, primarily because Medicaid covers things that commercial health insurance doesn't cover, that people with disabilities often need to live their daily life, okay? But if you see in the light blue line, that's for older adults. It's only up to 75% of the federal poverty level, right? So if your income is over that, you're not eligible, okay? Then you see in the light green, low income parent is only 60% federal poverty level, and yellow are the low income adults. This is the Medicaid expansion, 19 to 64 with income up to 138% of the federal poverty level, which this year means for a household of one about $22,000 a year in annual income. Okay. So when we brought that group of people on, the government really tried to sweeten the deal. So for the first 3 years of that coverage, the government paid 100%. Remember I was talking about the matching? The feds always have to pay a fixed percentage of the cost, and the general rate is 50. For that group, it's 100. And then it gradually over time in statute was reduced. So now it's at 90%, 90, forever, until that statute gets changed. Okay? So the low-income adults, they're called Granite Advantage, they're called Medicaid Expansion. That is the group for whom the vast majority of the changes that are coming with respect to work requirements, community engagement requirements, double eligibility checks, additional co-payments, that is the group of people for whom the changes are being applied. So just want to be clear about that. And this is also the place where I want to say, Christine undersold a little bit the funding that Medicaid generates for New Hampshire. New Hampshire Medicaid is actually a more than $2 billion program and any given year. At least half of that is federal. But the Medicaid expansion, because the federal payment was so high, has brought more than $3 billion with a B dollars into this state since 2014. So that group of people brought $3 billion of federal dollars into the state. Okay. So what does it look like in reality, this pie of Medicaid enrollment? So this is the January 2026 New Hampshire Medicaid pie enrollment. And pound for pound, Medicaid is mostly children, right? The orange slice, those are all those babies and kids. And then in the red slice is the expansion adults. I should have kept my colors consistent. It just occurred to me. I have on one side, I have them in yellow, and on this side, they're in red. That's really bad design, I'm sure. So anyway, on this page, they're in red. The dark blue are our folks our elderly folks, people over 65, and people who live with disabilities. It's about 23,000, so not even 15% of the total pie. The light blue is sort of a mishigas of pregnant or postpartum women, the low-income adults, the low-income parents. And then we have a tiny little slice that are our kids with really, really significant disabilities that they need almost nursing facility level of care at home. So that's about 1,000 kids, okay? So that is today's in New Hampshire Medicaid pie. So you can see that the expansion adults are about 46% of the pie. So those are the folks in red, for whom these changes are the most significant. Okay. So there are some new laws that were passed that impact Medicaid. One was the state budget, and the other is the One Big Beautiful Bill Act that was enacted last July. And they have similar changes that they apply. They just do them at different times, and for payments, they do them at different amounts. So you can see here that mostly it's about applying premiums and applying work requirements. That's enacted both within the state budget and within the federal law. The federal law also increases eligibility checks to twice a year. Right now, they're for everyone in Medicaid once a year. And that is also a return to pre-ACA practice. When the Affordable Care Act was enacted, all of Medicaid eligibility enrollment went to once a year, because the truth is, the more things you put in front of someone's enrollment or in front of their point of service, the harder it is for them to get enrolled and the harder it is for them to stay enrolled. And so for the last 10 years, we have streamlined eligibility to make it just once a year, and we learned after the COVID pandemic was over that the more you require people to do to sign up or to stay enrolled in insurance, the more people you lose in the enrollment process. Sure, it's like a basic principle. Okay, so what you need to know is that the upshot of these types of changes, they frustrate enrollment, right? They make it harder for people to get enrolled, and they make it harder for people to stay enrolled. And some of the changes, which we won't go into tonight, make it harder to pay the providers that Christine was talking about. Not just because more of their clients are showing up without a payment attached to them, but because other ways that the state has of reimbursing providers who participate in Medicaid are being limited and cramped. But that's for a night when everybody has trouble sleeping. And we need something super exciting to keep us awake. Okay. Okay, so you can tell I love my pie charts. So remember, this is what we're talking about. So if this is our pie chart and the slice, I want you to see with my very basic design skills, who some of these changes apply to visually. So the New Hampshire state budget added premiums to some of the families with kids and to the Medicaid expansion families. So again, Medicaid expansion is known as expansion. Medicaid expansion, it might be called Granite Advantage. It can go by all of those names. So the premiums that the state budget applies apply to a fraction of the red pie, red slice, the expansion adults. And for those expansion adults, they're going to have premiums of about $60 to $100 a month based on their family size. And this is for expansion adults with incomes from 100% of the federal poverty level to about 138. So at the very high end of the income eligibility for that group. And just as a reminder, a household of two at those income ranges from 100 to 138% of the federal poverty level is about $21,000 to about $29,000. So those families will pay premiums of between $60 and $100 a month. That's supposed to start in the third quarter of this year. Then the orange slice are premiums that are going to be applied to our higher income families with children. They're called CHIP families. And they're going to have premiums closer to between $190 and $270 a month. And just as a reminder, for a household of two, those income ranges go up to about 255% of the federal poverty level. So for a household of two, that max is $55,000, $55,000. Okay, so those folks are going to be responsible for paying for premium. The One Big Beautiful Bill Act adds work requirements, more frequent eligibility checks, and eventually additional cost sharing. The work requirements are meant to go into effect at the beginning of next year, at the beginning of 2027. The double eligibility checks, remember we do it once every 12 months now. They'll start doing it once every 6 months, also in January of 2027. And that will be for the entire red slice. And then in late 2028, they'll have co-pays for certain services, and it'll be $35 a pop. Okay, so these changes are coming, but they're not coming equally distributed across the Medicaid pie, as it were. And the reason is, this is where the FMAP, the fixed percentage, is really important. By having policy in place that frustrates enrollment primarily for this group of people, for the expansion population, the federal expenditures come way down, because remember, they're spending, or they're paying 90% of the costs of those 50,000 people, right? So if you really did it based on cost, who costs the most are really complicated, fragile people cost the most in Medicaid. Our elders and our people living with disabilities, right? And nobody wants to go there, right? But the reason that they could get so much juice out of this is because from the federal expenditure perspective, the money is all there. From the state budget, from the state Medicaid perspective, that's not where the lion's share of the Medicaid spend is. So it's not saving New Hampshire's budget anyway. It's saving the federal budget money. Okay. And in addition to this, let me end by saying this for the third time. These kinds of policies make it harder for people to get enrolled and stay enrolled. Okay? The fewer people that are enrolled in insurance, the more financial pressure there is on all the providers. There isn't a special place that only Medicaid members go to get their health care. They're just people, and they go everywhere, right? So the providers that care for them are the providers that care for people with commercial insurance, people that care for veterans and military families, people that care for people with Medicare, right? People that don't have any insurance of any kind. They care for all of them. So that creates additional financial pressure on providers. The other thing probably creating additional numbers of people who are uninsured is that simultaneously, the healthcare.gov, which is our individual marketplace, that's where you go. You can buy insurance on your own, individually, and there's financial help available if you buy through healthcare.gov. The financial help is often referred to as subsidies. In 2025, there were these really, really, really generous subsidies that had been in place for 2 or 3 years. Really, really generous financial help. It was available to more people than in the past, and more of it was available. So that extra help all expired at the end of 2025. And nationally, we're already seeing some decreases in enrollment. You can see the enrollment from 2025 in the blue bar was about 70,000 people in New Hampshire signed up for a healthcare.gov plan. And then we've already seen a reduction. I think it's about 7% of folks who have enrolled for this year. And there are national news stories now that are indicating that now that the first quarter is over, we'll probably see more reductions. So that's going to create additional financial pressures also. So my big takeaway is uncompensated care is coming. Uncompensated care is exactly what it sounds like. It's care that providers provide for which there's no reimbursement. So the things that I've left in bold are the things that are coming that are going to really, that we've just talked about, that are really going to impact people in New Hampshire. Remember, it mostly applies to the expansion population, otherwise known as Granite Advantage. But it's not only that. State budget also applies some premiums to some families with children. Everybody it requires work requirements. And the things that are not in bold are the changes that are happening to how we can finance providers aside from who gets enrolled in state. Those things are also being cramped, but that's not our discussion for tonight. Okay. So, if you are trying to figure out, if you are a loved one, and I think we have one of those insurance cards that they said that we might be on Medicaid. If you can go online, go to New Hampshire Easy, go to the DHS website, and click on there, you'll see where it says benefits in the red circle. It says right underneath it, Granite Advantage. That's how you can confirm for yourself or for the person that you're working with that they're in that eligibility group. You can also call the Department of Health and Human Services and ask them which eligibility group you are in if you are covered by Medicaid. Okay? Ask them whether you're in Granite Advantage. So that's it. That's the end of my speech. I'm going to hand the microphone back to Christine. We'll be doing question and answer at the end. So thanks for following along.
Thank you, Deb, and thank you for correcting my horrible note. You just undersold yourself, that's all. So as Deb noted, it's a much larger impact. So I'm now going to turn it over to Chris McCracken, who's the CEO and president of Amoskeag Health, one of the federally qualified health centers in New Hampshire, who will explain the impact to community health centers and particularly PERS and her patients.
Thank you so much. Appreciate the opportunity to chat with you a little bit. I may not be the most skilled at managing paper, a pointer, and holding this, but I'll do my best. So we are going to chat a little bit, just high level, about what a federally qualified health center is. So the purpose of establishing federally qualified health centers, 1965, it's been around almost exactly the same amount of time. And we really didn't have a great infrastructure in the country to care for people who were in that bucket that didn't get services paid for in any other way because of the lack of coverage for working adults who needed insurance and didn't have access to it. So we've been around a long time. We've been in town for over 35 years. And I would say, I'm going to talk about a lot of things, but we've got my colleagues here from the Mental Health Center. Community mental health centers are a very similar safety net to make sure that people get services. But just high level, I think what we offer for services includes primary medical care, prenatal care. We deliver about 350 to 360 babies a year. We have a podiatrist, we have an optometrist. We offer chronic disease management like a nutritionist. Because of all those babies, she also does lactation consulting. We've got behavioral health. We've got clients who come to us because they might have a substance use disorder problem. We've got services that we provide in the community, like an ACERT program, working with the local police department. We've also got a collaboration with the Mental Health Center, where our clients from the Mental Health Center can get primary care services from us on site at one of their locations. That's an important collaboration. We have clinicians in the school district. So we collaborate as much as we can with our partners in the community to make sure that our folks are getting access to all of the things they might need, like medication and referrals to a lot of programs in the community. And I'm very proud, our staff is here with us today on the side. We got 3 of our staff members that help with the new patient process and also help with Medicaid enrollment, which is one of the reasons that we're here talking today. So if you have any questions, you're welcome to stop by and get some more information. So federally qualified health centers, and I'm just going to use this. So where are we located? We're located in 5 different locations. We've got a site on Elm Street, which the former name was Child Health Services. We serve about 6,000 children a year, just to kind of give you a sense. We have a site down on Hollis Street, which is the old tiny tot land near 900 Degrees Pizza, if you like pizza. It's a great location. We also have a site on Elliott Hospital's Doctors Park, and we have a site within the mental health center called Pro Health. And soon we'll be opening across the bridge on the west side at the Mark Stebbins Community Center, which is also going to have a Boys and Girls Club right next door. So if you know where Kelly Falls housing development is on the west side, that's a great place to stop by. That'll be opening in September. All right. So talking about the healthcare landscape, this is a lot of the things that we chat about. What are the needs in this community? And in particular, what kind of services are we seeing and what are the needs? So I always like to give credit, and our local health department here in Manchester is fantastic. Anna Thomas is the department director for those services, and they engaged Steve Norton to do a study for them and pull together some of this data. So I want to give credit where credit is due. These are not my graphs, and I did not write this. But I think this is an important thing to see. These are the adult Medicaid patients receiving preventative services in 2024 by provider. And you can see divided up by group. So the first bar is Elliott, and in blue is adult expansion. So that's the focus population that we're talking about today. So the biggest provider in the community with about 3,600 patients in that particular population is Elliott, followed by Dartmouth, followed by Amoskeag, and then CMC. So those are really big providers of care, but as Deb was saying, any office can accept Medicaid. And so just because you don't go to one of those facilities doesn't mean that this could not be an issue for you personally or for your loved one who may be benefiting from Medicaid. Here we go with the turning of the pages. The next population is children that are receiving WellCare services in Manchester. And as you can see, we're kind of the third biggest provider of pediatric services. So all those babies that we get the care, provide the care for, that we can retain for family services, we absolutely love to keep taking care of. And then this is Medicaid children receiving mental health services, behavioral health services in the Manchester area. And you can see, again, we're kind of the third largest provider, and that's also because of our services that we provide in the school district. So this quote is not mine, but I think it's important. For both of the largest safety net providers in Manchester, the Mental Health Center of Greater Manchester and Amoskeag Health, uncompensated care is on the rise. Okay? And that was something that Deb was just talking to you about earlier. As people start to lose their health insurance, the mental health center system and the federally qualified health center system, we're required to take care of everybody no matter what their insurance status is. So my goal was to kind of give you a sense, how has it changed since the implementation of the changes of the Affordable Care Act, or ACA? So for myself, I started working at Amoskeag Health back in 1996. So I'm hitting almost 30 years with that organization. That's all right. Patricia Carty in the back beats me. She's got almost 40. So you can kind of see Medicaid expansion begins here in 2014 on this timeline. And you can see as time goes along, the number of patients that are uninsured and the number of patients that are on Medicaid. After 2023, there was that public health emergency that had been in place because of COVID came to an end. And I know just from our roster, we lost over 1,000 patients off of Medicaid. People didn't know. They had been assured that they were safe, that their coverage would continue. And a lot of people, despite a lot of efforts to communicate out and warn people, please watch and make sure that you're getting re-enrolled. Life is complex, right? And if you've moved, if you've lost your computer, if your email changed, address changed, how easy could it be to potentially lose track of that data in the middle of everything else? And then this is one to give you a sense of how our Medicaid expansion has improved access to substance use disorder services. So I went back to 2012, which was 2 years before Medicaid expansion started. And you can see we treated under 1,000 patients for substance use disorder services back before Medicaid expansion. And if you go to the current season post-COVID, so COVID hits in 2020, you can see just how high. That was almost 10,000 patients that access care for a substance use disorder related condition. And then when that PHE ends, that public health emergency, all of a sudden those numbers start going back down. So as you can imagine, those of us sitting in the room that provide care, we don't want a cliff. We don't want to see patients who go to refill their medication and suddenly can't get refilled. We know that patients need those services. So why does Medicaid matter? So think about it. Before folks, when the ACA was implemented, it helped people access care that maybe they couldn't previously afford. They could follow through with a referral if we suggested, oh, it looks like, your heart's not great, we really want you to see a cardiologist. Well, there's no cardiologist that's necessarily offering services for free, right? But our partner organizations help and take our patients and get them established. If you got a medication, you need to get it refilled, you do that when you have coverage. If we want to send you to get an x-ray because you fell and we want to make sure that you didn't break anything in your wrist or your leg, we could do that. If you needed a specialist. So one of our family practice physicians, family medicine physicians, Dr. Fry, used to tell this story. She had the same patient on her panel for 15 years. And when she started working with him, he was in his late 30s, early 40s, but diabetic, early onset diabetes. And they had such a hard time getting sugars under control. And for years, he was off whack. So they want you to be below 7, and he was chronically at 8 or 9. And that starts to get into a dangerous area where maybe you're going to have an impact to your vision or you're going to lose a limb. And all of a sudden in 2015, he had his first healthy A1C below 7. And she said, so-and-so, I'm not going to repeat a name, what happened? This is like a miracle. Your numbers look great. And he said, well, I'm not cutting my pills in half. Because he worked construction. He worked full-time. He had a full-time job. But he could not afford to keep that medicine filled. And that's where you talk about that impact and why we're worried about seeing people fall off. Because your healthcare requires continuity. How many of you have had at least one time in your life where you took a regular medication? All right, that's a lot of hands. Do you know how much it would cost to buy that medication with no insurance coverage? It's expensive, right? So that's really what we're looking to do. We're looking to prevent people making horrible decisions between paying their bills, buying healthy food, putting very expensive gas in their car, managing their rental expenses, which continue to go through the roof. These incomes are not very high, right? $50,000 a year for 2 people is not a lot of money. And I think we have to be concerned about what is this really going to mean. So what is at risk? Work requirements are going to cause a lot of burdens. They're going to cause the biggest burden is to the patients that are benefiting with those services, but it's also an interruption in care. So what does the doctor do when suddenly I can't refer you? What kind of documentation might you need filled out so that you can say, I can't work right now, or I'm taking care of my mom who's ill and I'm her caregiver, right? So there's strain all throughout that system. Patients who are avoiding care because they can't afford to pay their $35 copay sudden that they didn't have as an expense. Patients who don't get their medications filled or go get visits when they need to have them. Don't go to the specialist when they really need them. The end result is people get sicker. That's the bottom line, right? Hospital EDs get busier. That impacts everyone in the room. And for all those people who are going to show up there when they're really ill, if there's no payment coming along with them, that cost is going to get absorbed by all of the private health insurances going up because the costs have to get covered somehow. So it's really concerning. Small employers who really have taken advantage of that marketplace. There's more small employers in New Hampshire than large employers. They've relied upon that marketplace and those subsidies to enable their staff to get coverage. So the safety net, your safety net folks like ourselves, Mental Health Center and others, we can't see as many patients, right? Because all of a sudden the revenue that's coming in is shrinking and our costs are not shrinking. So it's yet one more strain. So we just want to make sure that people are kind of seeing that full picture. This is not something where there's a drop of a pebble and it goes straight to the bottom of the pond, right? Those rings come out from that pebble and influence a lot of people, and it's pretty scary. Thank you.
Thank you, Chris. So now we'll open it up for discussion if anyone has any questions or comments. And I hope that you do leave with a sense of hope, because there are things that we can do to help our friends and neighbors stay insured. There are things that healthcare organizations are already doing to make sure that their patients stay insured. But we want people to be aware of what's coming so that they can take action and they can help their family members take action, and also their friends and neighbors. So Jake, our friend from New Futures, has a microphone if anyone has any questions or comments. Yes.
I know this is local to Manchester, but there's so many areas, especially in the Monadnock region, that are not being serviced. We don't have your health care, we don't, the free clinics, and there's so many people who don't understand what's going to happen to their Medicaid. And are you planning to come to us at any point?
Yes, so we take requests. We've scheduled different events around the state. We started this over a year ago in the North Country. But if you would like us to come to your town library or a community organization, we are happy to. We can take your contact information and we're happy to make that connection. So thank you for raising that.
I've narrowed it down to 3. I can give them all to you if you want.
Sure.
I thought about a few things. I had a classmate I grew up with in a small town that went to Afghanistan in the Guard. And he didn't get qualified under TRICARE, a lot of things being in the Guard. With everything going on, what's going to happen with that? He really fell through with a lot of things that he came back a different person. And the VA doesn't cover everybody in the Guard for everything you might think.
Yes.
I'll just quickly, I'll throw the other ones out. This is a question I have. What about SSDI and people waiting for a decision? They don't have SSDI, they're waiting. Are they gonna have to work while they're waiting? Because you can't. I know that.
So I think Deb wants to answer.
So the good news is, to some extent, there are exemptions for the work requirement, and a person living with a disability, which is likely to be in those exemption categories. There's a number of other categories. So You could be a former foster care kid, someone in the AAPI population, someone who has caretaking responsibilities for someone who is 13 or younger, a veteran with a disability, someone who is, there's a big catch-all category, someone who is considered medically frail. And the state and the federal government are together going to define what can count as medically frail. Those folks will also be able to be exempted, as well as people who are already hitting the work requirement because they receive SNAP or TANF, someone who is undergoing substance use disorder treatment, someone who is either pregnant or is postpartum within 12 months are generally going to be exempted. However, all the details about how you demonstrate that a person is exempt, we're still waiting on, because the state Medicaid program is still waiting on the federal government to give them the details that they want. And then I suspect that will probably come, at first we thought it was going to be in January, and then we thought it would be March, and here it is May. So we're hoping before the end of the fiscal year, by the end of June, that the state will have more information about how you demonstrate those exemptions. But we don't yet.
I just have one more question. I promise I won't talk the rest of the night.
No,
Plus, I
it's
have
okay.
the mic.
Yeah, we're here.
Quimby, I'm on Quimby. I
Yeah.
am in senior housing. I'm 50 almost, and
Yeah.
I'm the youngest there.
Yeah.
A lot of people in my building are either on Quimby or Slimby with Medicare, which is, I use my old Medicaid. I'm not on Medicaid. I'm not on it, but I'm on Quimby. You didn't address that too much. Is that something you want to talk like after, or is that something you know a lot about, or what's?
We don't know. I mean, we know enough to be dangerous. What I want to say is that Quimby and Slimby's are not considered full benefit Medicaid beneficiaries, but Medicaid does provide the financial help that the Quimby Slimby provides. So as not full benefit Medicaid beneficiaries, wouldn't be required to follow through with the Medicaid work requirements for the additional premiums or cost share. So qualified low income Medicare beneficiary is a Quimby, and something low income Medicaid beneficiary. So those are financial assistance that Medicaid pays for someone who is Medicare eligible, and their income falls to a certain level that Medicaid helps to either pay outright or defray the cost of their premium and out of pocket or Medicare. That's what Quimby's and Slimby's are.
So one of the suggestions that we have for you tonight is to sign up for our newsletters so that you can get updated information. We're working with the state to keep people informed. And so we're updating our website and also releasing resources on Facebook and other social media so that you can have updated information. And we also have a sign-in sheet that you can add your name to if you would like to get more information. It's my understanding that the federal government is going to do a ad campaign to help educate people about the upcoming changes, and that the state will partner and use those ads, but then also might produce their own targeted to New Hampshire. And CMS is supposedly going to release those guidance documents on June 1st. So hopefully we'll know more in a couple weeks. It will take the state and us time to digest that information, and then we will update our documents as we learn more. Thank you. Does anyone else have any questions? Yes.
So if you want to get more information, Now, the things you covered here today, where can you go?
From the website, that is on here. So, I'm sorry, I have progressives and I can't. nhneedsmedicaid.com. And then we also are on Facebook and Instagram.
How about if you like want to talk to somebody?
We're happy to wait after the event and talk. And also, we would recommend you calling your DHHS district offices if we can't answer the questions. Yes.
So my question is regarding something coming that has not started yet, but currently I'm having difficulty with, even though this hasn't yet happened, but I'm looking for a specific physician or a specific place, all of whom are not accepting Medicaid, they're not accepting Medicare. Some will accept Medicare, but not Medicaid, so it's really difficult out there, period, to find, despite these upcoming changes. So one place will take Medicare, not Medicaid, others will take Medicaid, not Medicare. It's a mess. And so when this actually does come into place, I think a lot of practices are already, a lot of hospitals as well, are gonna not even accept those insurances. So apparently they will accept insurance through an employer, but not for people who are on state aid, people who are on state insurance. Again, the two Medicare, Medicaid programs. So what do we do? It's really sad to think about what's coming.
It is sad. So there are primary care practices like community health centers who will take all patients regardless of their ability to pay. And community health centers work with specialists in their area and sometimes can offer discounted care that way. But not everyone in New Hampshire has access to a community health center, unfortunately, or a mental health center. So like in the Monadnock region, we don't have a community health center over there that is open. So I would suggest reaching out to community health centers in your area, talking to their patient navigators who can help you find insurance and also other services. But please do sign up for our website and alerts so that we can help you access information. We are a broad coalition, right? So we work together on many different issues, including commercial insurance. And so when people ask questions in these types of events, it helps us educate the state and lawmakers on what's happening and what's coming down the pipe. So if you do have questions, we would appreciate hearing them either now or later. You can reach out to us, like social media or website, because it helps us know what to advocate for at the state level for you.
And an additional question, please.
An additional question. So the impact of the beautiful bill, one of the OBBA, I think, so my question is specifically around people who have insurance and have been getting treatment, and then they have to get recertified twice a year. All of that, people, I think, before you know it, people are going to say, I don't have insurance. I don't want to deal with all of this. And so they can get free care. So it's too much headache to try to go through this process. Even seniors, families with children, and sometimes they don't have transportation. So then they have to call to get a ride and all those extra efforts. And so, you know, the time that it takes to wait to be picked up, and then they're not there at their appointment on time. And just, you know, people just say, you know, screw it. I'm just going to show up and get free care and not bother to go through these processes.
Yes, you're right. My husband is in the construction industry and he's covered under my insurance. His coworkers are not. They've already dropped their insurance because they couldn't afford their marketplace plans. These are small business owners in the construction industry. New Hampshire is going to be affected. There's no doubt about that. The changes in the Big Beautiful Bill will affect all of us. But we hope to work together with all of you to minimize the impact. Can there be things that the foundations do for to minimize the impact. We have a lot of philanthropy in the state of New Hampshire, which is great. We don't have a lot of state revenue, so I think that our foundations are probably going to be one of the places that people look for help. But you're right, you're absolutely right.
Thank you.
Thank you. I have a question. Is there a way that we can vote against these changes that are happening? Because these changes are gonna be affecting everybody, not only the young ones, the youth and elders. It's literally everybody who's going to be going through it. Is there a way that we could vote against what's happening?
Yes, so I should say, I work for a nonpartisan organization, but there is an election coming up in November, right? So there's midterms. Know who you're voting for. Please vote. So you have midterms in November, and that's a lot of congressional overturn possibly, and then we also have state elections at the legislature. So as Deb noted, these choices were made by state elected officials and also our national Congress and the Senate. So please do vote and know who you're voting for when you do. There's always an election coming, so there's always hope to make change in the next election. I'm not giving up. Yes.
I just want to now follow, because I know she just said about like the young, but for the refugees and the immigrants, I know it's going to be tough because inside the state already, they're already just like making girl to put all those people down, and I don't know what's going to be their consequences for all of this and how they're going to get help.
And so coming in October, I believe, there are certain refugees that will lose their Medicaid insurance.
Yeah.
So that doesn't only affect refugees, right? It affects their healthcare providers, it affects their children who were born in the United States, it affects hospitals and their healthcare system. So thank you for mentioning it. It's going to be a huge impact, especially on healthcare organizations like AMSCAG. You have over 60 languages spoken at AMSCAG. So yes, they can go to AMSCAG and access care and access translation services, but what happens when they need to see a specialist that is not on AMSCAG's payroll or in their network?
I had a wonderful job by the way.
Oh, can you use the mic? Please?
Oh, well, I was gonna,
Oh, I'm sorry.
I had to do a question, sorry.
I was looking at Kristen's head and
Yeah, no, it's okay. It's just quick. I wanted to address here, about the next election or whatever, and Mary and I here, we're both representatives, from Manchester. We did not vote for this, to happen. We voted against this, but, yeah, I just wanted to say the people of the same party of the big, beautiful bill, you might want to steer clear for those people. Yeah, so. They're the ones that, it was a partisan vote, big time for these changes. And ironically, a lot of the people tend to hate the federal government who voted for this, yet they're saving money for the federal government, which I don't really understand, but yeah. So.
no, and
It's not saving the state money.
it isn't, and one of the changes that we didn't talk about are the changes to how hospitals are taxed and the reduction of that tax. That tax reduction will affect the state revenue. It's billions of dollars, $3 billion for the Met.
There's a change coming that reduces a tax that is placed on hospitals in New Hampshire, and it helps to generate the state share. Remember how there's like a fixed percentage that the feds always pay? Well, the state pays the other half, right? So there's in the One Big Beautiful Bill Act, there's also a provision that limits how we generate that tax, and it's going to decrease revenue that's going to be available to the state budget writers to fund the Medicaid program eventually. So I know, it's like ridiculous. Mariana.
And then wonderful job too, by the way, too. But one thing I did want to add related to immigrants, refugees, etc., is that coming in January 1st of 2027, there's a select group of individuals, primarily immigrants, that will access to tax subsidies entirely. So they may be ineligible for Medicaid. Ultimately, they'll be put in a situation where they have to buy a plan through the marketplace, and they may or may not be able to afford those plans, going from $250 all the way up to $1,000 for a family. So those are, again, just another explanation as to why people continue to lose access.
And the work requirement is going to be really tricky in another way. I just remembered this. If someone is in Medicaid and they lose enrollment because of the work requirement, either they aren't eligible or they get kicked out because of the work requirement, they are also then ineligible for marketplace subsidies. So they can't get financial help and purchase on their own. So compliance with the work requirement will be really important. I mean, for obvious reasons, but they will be foreclosed from getting financial help from other places.
Yeah, so I have a question on earlier slide. It said 7.3% preliminary number of people that dropped off the ACA. The final number was actually 6.1%, so it's a little less than that. Did you guys take into account the fact that veterans since August 10th of 2022 are now eligible for VA that weren't previously? I'm one of those. So I have VA coverage now that I previously did not have. So there's about 6,500 of us that have gone that way.
Yeah.
So we don't have we don't need the ACA for that.
That's
so
great.
What is the real number? Do you guys have any
That's the best number I've got. It's from the open enrollment files from the Centers for Medicare and Medicaid Services.
Because
that is a real number.
Okay.
I understand that.
The tragedy of it is not as bad as it looks, is what I'm saying. It's because 6,500 people approximately have switched over to VA, and about 2,500 people in New Hampshire have switched over to health sharing plans, like health sharing ministries.
Yeah.
So they wouldn't be utilizing this. It's not as though they don't have insurance, and also by the way,
we don't know that. There's no data that says where they are insured. At least not that I can see. Like the data that we took from CMS is really about the changes in enrollment in healthcare.gov from year to year.
Right. And by the way, Slim,
Thank you.
That's my business.
The data for Medicaid is current. It's up to 20. The data would be for 2025, showing up now for 2026. So your number's already shown in that data that they got. So I don't want to be rude, but your data is already showing there. And I'm a researcher, so there's that.
And I think also, thank you for clarifying that, the insurance department usually releases its own enrollment data, but that has not happened yet because these changes just went into effect 5 months ago. So we're still seeing things change. Does anyone else have any questions? Yes.
Thank you.
So I have medical insurance through both having Social Security and state money, but it doesn't, there's tier 1, there are different tiers that I'm familiar with, and I'm required to meet specific deductible amounts until the medication is covered. So that too is nuts. You follow me?
Yes.
No.
I missed the last part of what you said, sorry.
So I'll just repeat myself.
Can you, I'm sorry, we can't hear the interpreters.
So my point is that you have to meet a specific deductible before they actually will cover specific meds.
Yes.
Given what tier each med is, tier 1, tier 2, tier 3. That's another incredible difficulty that, so if you have to spend a significant amount of money before they can even begin to cover those categories. And it's getting worse, I think, for so many of us.
Yes. Thank you.
Does anyone else have any questions or comments? Please, for follow-up, as I've said too many times now, check our website. We are working with the state to get concrete information out when it's available. So please do check in with us. And if you would like us to come to your areas, please let us know. We are happy to do that. We are not being paid to do this information session. We are trying to help people understand what they can do and what they can help their friends and neighbors do to stay insured. So that's why we're here today. So thank you very, very much for